Hello, my name is Paul Blakesley, and this is my research proposal discussing the incidence of malnutrition in hospitalized elderly patients. In developed countries, malnutrition is estimated to be present in 20 to 50% of patients at the time of their admission to the hospital, or developed during their hospitalization. Variations in reported prevalence can be related to the hospital settings, as well as the tools used to identify it. Malnutrition continues to be underdiagnosed in hospitals. If left untreated, patients may decline further during their hospital course, as malnutrition itself has a negative effect on clinical outcomes, such as 30-day readmit rate, length of stay, mortality, as well as increasing financial burden on hospitals due to poor clinical outcomes. Some populations are more at risk than others of developing malnutrition, one being the elderly. Chronic diseases, food access, dentures, anorexia of aging, and medications lead to decreased mobility, limiting activities of daily living. All have impact on nutrition status, leading to more rapid progression of sarcopenia due to undernutrition and eventually malnutrition. The older adult is one of the fastest growing populations in the United States. Therefore, focus should be on identifying, assessing, and making appropriate evidence-based interventions to those high-risk patients. The aim of this study is to explore the incidence of malnutrition in a rapidly growing high-risk population. Identification of those at risk is part of the process to address malnutrition in the hospital setting. My research question is, what is the incidence of moderate and severe malnutrition in patients aged 65 years of age or older admitted to a tertiary care hospital in Portland, Maine in the years 2017 and 2018? Definitions. Undernutrition is the insufficient intake of nutrients to meet an individual's requirements. Malnutrition, which is deficiencies, excesses, or imbalances of energy or nutrient needs, and sarcopenia is the loss of muscle mass, strength, or functional ability. It is expected that globally by 2050 the population of those 60 years of age or older will double from 962 million in 2017 to 2.1 billion. According to the United States Census Bureau, 20.6% of the population of Maine now is age 65 years of age or older, which places it at the highest of all states in the percentage of population from this age group. Sarcopenia, or loss of muscle mass and functional status, increased rapidly by undernutrition is frequent among elderly hospitalized patients. Siri et al. Found that sarcopenic patients are more likely to die 3 months after discharge compared to non-sarcopenic patients. Assessment of nutrition status in elderly patients have unique barriers. Those who are unable to stand or are bedridden will not be able to easily be weighed using a scale and can limit a key part of malnutrition identification. Changes in weight over time is an important aspect to evaluate during nutrition assessment. Alternative anthropometric measurements can be used to evaluate and monitor for changes. Monitoring changes over time will be telling of the effectiveness of interventions put in place of those at risk. Malnutrition in hospitalized elderly is an increasing trend globally. Underdiagnosis of malnutrition may be a large part of the problem. Using a validated screening tool to identify those at risk of malnutrition should be used. Determination of the etiology and severity of malnutrition in a standardized way is also important when evaluating patients found at risk. Hudson et al., using the joint American Society for Parenteral and Enteral Nutrition and Academy of Nutrition Dietetics criteria for identification of malnutrition, were able to identify patients who would have longer length of stays, mortality, and readmission rate using this tool. Screening and identification is only the first step in addressing malnutrition in the elderly. Following the nutrition care process and making interventions is imperative. All steps are equally important. Currently, there is no data on the incidence of malnutrition in this age group specifically in our hospital. Knowing we'll be able to enable the facility to focus resources as well as set benchmarks for monitoring and addressing this issue. This is a retrospective chart review. After obtaining approval from the facility's Institutional Review Board, a query will be made to the Enterprise Reporting, which is a hospital team specifically trained in retrieval and handling of data sensitive from the electronic medical record. The goal will be to review all patients aged 65 years of age or older admitted to the hospital in calendar years 2017 and 2018. This data, in Excel format, will be sent to team members and uploaded to our database for statistical analysis. R version 3.6.1 will be used. The following data will be retrieved and explored for significance will be positive MST score, presence of ICD-10 diagnosis code, E43 and E44, presence of documentation by malnutrition by the registered dietitian, age, date of admit, date of discharge, presence of another admit to the hospital within 30 days of the last discharge, and mortality. All patient records will be de-identified and ages will be reported in 10-year ranges, such as 65 to 75, 75 to 85, and 85 and older. This will limit the potential identifier of those elderly patients. Only the primary investigator and analyst will have access to the original data set and will remain in electronic form on password-protected computer, hard drive, in a locked office. Upon completion of the study, all data sets will be destroyed. The retrieved limited data will be analyzed using descriptive methods. Statistical tests will run comparing groups using Fisher's exact test, Pearson's t-test, and chi-squared. Confidence intervals will be calculated and a significant p-value will be less than 0.05. Specifics to be explored are the number of patients identified with ICD-10 diagnosis, E43 and E44, and there will be and if there was an increase between the 2 years. Comparing these identified with a form of malnutrition and those without, is there a difference in length of hospital stay or a higher rate of returning to the hospital within 30 days? This study is unique as it will be conducted in an area of the country that demographics have a higher population of those 65 years of age or older, which will allow for a larger sample size to analyze. Being a retrospective chart review, there will be no enrollment. It will be a convenience sample of the population who are admitted to the hospital at the time period specified. This might limit the ability to come to conclusions about the prevalence of malnutrition in the surrounding community, as hospitalized patients could have some more health concerns than others, and therefore be more at risk. The aim of this study is to look at the incidence of malnutrition in the hospital setting specifically, though. Another limitation to note is the use of electronic medical records may have variations in documentation, especially towards the trend to document the negative occurrences, as well as errors in human reporting and documentation. With the results of this study, future research can be done on specific interventions or timing of interventions that will have the optimal impact on addressing malnutrition. Furthermore, other age groups and the incidence of malnutrition should also be explored. Thank you for listening. Here are my references.